Good afternoon, ladies and gentlemen. My name is Jeremy Samet and I'm a Research Fellow in the Health Program here at the CIS. It's my pleasure to introduce today's speaker, who is the Federal Minister for Health and Sport, the Honourable Sussan Ley MP. Sussan Ley has been the member for the New South Wales seat of Farrer since 2001. In September 2013, she was appointed Assistant Minister for Education with responsibilities for childcare. In December 2014, Minister Ley was appointed to Cabinet and took over what had become the contentious health portfolio. I think it's fair to say that amid a politically challenging first year and budget for the Abbott government, health stood out in creating problems due to the backlash against the government's Medicare co-payment plan. There were many good reasons for introducing a modest amount of cost sharing for GP and other medical services, and many of those reasons were in the CIS budget, CIS Target 30 budget repair kit, which actually proposed the co-payment, which was released in November 2013. But it's now history that the co-payment, in the words of the Prime Minister, is dead, buried and cremated. There are many lessons, I think, to learn from the co-payment's demise for those who are interested in health reform. The chief lesson appears to be that Australians simply refuse to give up health entitlements, even for the sake of budget repair and eliminating debt and deficit. I think we can rail against this and keep repeating the same arguments about ageing-related health pressures, but I suspect that this is going to produce diminishing returns in terms of generating enthusiasm for change. I think the alternative is to use this as an opportunity to reset the debate and to change the conversation about health reform. Instead of focusing on what will be lost by doing reform X, Y or Z, I think we need to talk about what might be done, what might be gained, both personally and for the nation, through health innovations that improve the way health services are provided throughout what is a $150 billion industry. These thoughts about reframing the health debate have been prompted in part by the title that we have been given for the Minister's address, which is Health, Not Health Finance, How Do We Better Manage Wellness? Given the events of the past year or so, that sort of sounds like a segue and a half. But I suspect some questions about health financing, budget repair and debt and deficit might feature during the Q&A. So thanks for coming, Minister. We're delighted to have you and welcome.
Thank you, Jeremy. Thank you for having me at the Centre for Independent Studies, and it's lovely to be with you all, many of whom I don't know, but I look forward to your questions. And I'll speak reasonably quickly because it's important that we do have that interaction at the end of my remarks. So thank you, Jeremy. I've been the Health Minister now for not quite 6 months, and I'm assuming that once I pass the 6 months target, I won't read the new Health Minister anymore. It feels like a lifetime, but it is an opportunity that I have been and I remain very grateful for. As those who know the political process would understand, one doesn't apply for a job in the ministry of really any government. Well, perhaps some privileged people have in the past, but you wait for the call. And for me, it was a few days before Christmas and the Prime Minister rang me and I was driving down the Hume Highway, which is a trip I make rather a lot. And he said, I'd like you to be the Minister for Health and Sport. And I was quite blown away and quite surprised and delighted. And since then, we've all been very busy and we've all been very interested. When I say we, I mean the team that surrounds me, because it's not an individual that does these things, it is a team, with lots of things, lots of reforms, lots of activity, lots of ideas, lots of travel, lots of consultation, and lots of listening. I met one of my predecessors quite early on in the piece, Michael Wooldridge, and he said, the average term of a health minister is 20 months. So if you want to do anything, you better get moving. And I suppose the approach I'm taking is, ministers come and go. But it is important that reforms remain and that what we might put in place today will last past the next election. The electoral cycle at federal level is short and volatile, as you know. Last beyond the federal election and make sense. And one of my favourite sayings, not mine, is that good policy makes for good politics. Just before I start my formal speech, I'm going to fly the flag for rural Australia because as a rural and regional member right in the heart of Sydney, it's important that I do that. As the member for Farrer, elected in 2001, my electorate covers about a third of New South Wales, 250,000 square kilometres. Malcolm Turnbull's covers 25. He's got more constituents than I have, which is an interesting statistic, but it gets worse. We're losing a seat in New South Wales. We're losing a seat. There's only 150 in the House of Representatives, so they have to be reshaped, as you know, to Western Australia. So at the next federal election, there will be one less federal seat in New South Wales, one less federal member of Parliament, and it's highly likely it will be one less rural member of Parliament. And I am quite likely to be standing, if my electorate survives and I do, on the top of Mount Kosciuszko and looking at the Queensland border. And that is quite a bizarre circumstance. So it's a very good thing that in an earlier life as a commercial pilot, I learned to fly, became a commercial pilot. I still hold my licence and I still use it to fly around my electorate. When we talk about the value of the Australian health system, value can mean a number of things. And Jeremy in his introduction said that I wanted to talk about essentially this. I don't want to be the Minister for Health Financing, even though I'm going to talk a lot about the budget and the dollars because, of course, that's our core business. I want to be the Minister for Health. So I often talk to doctors and they have an interest in policy because that's why they're in the same conversation that I am, and they've sort of come out of whatever they do day to day and they want to see health from a policy perspective, but I very much want to see it from an operating room perspective. So I always ask them questions about what happens to patients, what happens in their procedures, and what matters to the communities that they serve. So health financing is important, but I will put it in terms of value. So value to the economy, value to individuals, the value of a mixed health system with public and private delivery and financing all play a major role in defining our quality of life. On all accounts, the Australian health system passes the test. It does provide value to the economy, to individuals, to the nation. It is a strong system, a sophisticated system, a system that works. But it's also a system that can be improved, indeed must be improved, if we are to meet the challenges presented by an ageing population, increasingly costly emerging technologies, and the increasing prevalence of chronic disease. A healthy population is important for the national economy. A healthy population drives growth through a number of pathways. Labour supply, if you're in good health, the probability of your participating in the labour force increases. Absenteeism, rates are reduced when employees have good health. Ill health not only contributes to the decision to retire, but may also encourage other household members to reduce their workforce participation. Education. As I know too well, good health in childhood has been shown to increase education, participation and qualification levels. Savings. If people expect to live longer and healthier lives, it increases their propensity to save, generating funds available for investment. Earnings. Poor health negatively affects wages and earnings. The health sector is also significant in economic terms simply because of its size. In 2012-13, total health expenditure was 9.7% of GDP. In 2014, health service industries comprised 7% of the total labour force. So health expenditure helps to drive labour force participation and productivity. It can therefore be viewed partly as an investment stream. Importantly, health is a key component of individual and social well-being. Good health facilitates social participation and community cohesion. The health and well-being of communities is fundamental and of vital value in our society. In terms of both funding and delivery, Australia has a mixed health system. In 2012-13, 41% of funding was provided by the Commonwealth Government, 27% by state and territory and local government, and 32% by non-government sources such as individuals, health insurance companies, and injury compensation insurers. Through Medicare, the government provides universal health coverage. Our Medicare system provides subsidised access to medical services, while the states and territories offer free access to public hospital services. At the same time, the Commonwealth-funded Pharmaceutical Benefits Scheme provides subsidised access to pharmaceuticals. Both Medicare and the PBS provide higher subsidies for those using a higher volume of services while protecting low-income people. Medicare is built on the principles of affordable access to clinically appropriate services to Australia's geographically dispersed population. On the private funding side, the Australian health system also provides means-tested subsidies for private health insurance. This mix of public and private funding helps to ensure people with limited means or poor health have access to world-class healthcare, facilitate more choice around care options, such as people having more potential to choose their own doctor, and improve the sustainability of the health system as a whole. Most primary and secondary healthcare services are provided by the private sector through privately employed GPs, specialists, dentists, and allied health professionals. For example, around 120 million GP services were funded by the MBS in 2013-14, with a vast majority provided by privately employed doctors. The majority of hospital activity occurs in public hospitals, provided by health professionals employed by public hospitals. In particular, there were 5.5 million inpatient separations from public hospitals in 2012-13 and 14.9 million outpatient occasions of service. By comparison, private hospitals provided 3.8 million inpatient separations and 2.2 million outpatient occasions of service. This blend of public and private sector healthcare combined to deliver excellent value to Australia's patients who have access to world-class facilities and clinicians in a range of settings. Our new primary health networks will be important in creating a more integrated service between primary, allied and hospital healthcare. Many of the successful primary health networks are consortia harnessing the best skills and knowledge from a range of sources, including allied health providers, universities, private health insurers, and some former Medicare locals. Direct involvement of the private sector supports the delivery of new approaches and encourages strong cross-sector collaboration. The MBS Review Task Force will also be striving to improve outcomes for patients and deliver increased value in the Medicare services which are delivered. I announced the membership of our MBS Review Task Force, I think last week. Led by Professor Bruce Robinson, Dean of the Sydney University Medical School, the task force will include clinicians, researchers, health technology assessment experts and consumers. The task force will review the more than 5,500 services listed on the MBS to better align with contemporary clinical evidence. The clear focus of this group will be to deliver better patient outcomes and provide vital direction on the broad reform process of Medicare. At the same time, I have formed a primary healthcare advisory group led by former AMA President Steve Hambledon. The advisory group will investigate options to provide a better primary care structure, which more efficiently supports patients and practitioners to manage chronic conditions and the complex interactions between primary and acute care. Both these groups will provide expert guidance to ensure Australians can continue to access quality primary health care and to ensure that we have an effective and sustainable universal Medicare system. We also need to make it easier for patients to ensure their vital medical records are accessible to the multitude of healthcare practitioners with whom they interact through the course of an episode of ill health. The personally controlled electronic health record is being relaunched and renamed My Health Record. With 2 opt-out trials in planning, we will get this much-needed system back on track and functioning effectively for both health providers and for patients. The proof that the Australian health system performs well is evident from Australia's high life expectancy, which is one of the highest in the world at 82 years of age. Moreover, In 2010, the OECD found that of the 34 OECD countries, Australia was one of 5 which performed well in transforming money into health outcomes. The efficiency of our health spending is high, but can still be improved. So the value of Australia's health system cannot be doubted. Australia has a strong health system based on mixed public and private sector funding and delivery arrangements. The health system delivers good health outcomes which contribute to growth in the economy and social well-being. But this is, however, no place for us to rest and be complacent. The government will continue to pursue policies to increase efficiency and effectiveness, including demand-side policies such as providing information and empowerment to consumers through better e-health. Supply-side initiatives such as improved incentives to encourage doctors to provide services where they are currently undersupplied, such as in the bush. And system-wide changes such as providing a different type of funding to doctors for patients with complex and chronic conditions to ensure their needs are better met. The Australian health system is an asset of great value, worth protecting and worth improving so that it remains truly world-class. Just as valuable is the freedom for Australians to choose within that system, particularly in relation to where they want to be treated. This too is worth protecting, worth improving, and our government is committed and will continue to be committed to doing just that. Thank you, and I'm happy to take your questions.
Here to do the vote of thanks for the Minister. The University of Sydney has a Centre for Obesity Research that does quite a lot of good work. And a study of theirs that caught my eye recently was one that compared obese patients who enrolled in private weight loss programs and those that were enrolled in a government-funded weight loss program. The first they paid for themselves, the second they received for free. The first group was dramatically more likely to lose weight and keep it off. And the researcher didn't put forward a theory for why this should be so, but it seems clear to me that the first group had demonstrated a commitment to pursuing better wellness, whereas for the second, wellness was just a program that was happening to them. So much of chronic disease is a result of lifestyle factors and is only treatable with these kinds of wellness programs. But in these kinds of programs, it's crucial to bring patients along with you, because if they don't have that commitment, the program won't be effective. The Minister's remarks today were wonderfully rich and fascinating, and I think we've all got a lot to go away thinking about. But the part that was most encouraging to me was her focus on the patient's human experience. That when she meets with clinicians, that's what she asks about, not just about policy, but about how the patient, what the patient's experience is. And I think that as we move forward in looking at chronic disease, that will be the most important thing to keep in mind. And I know the CIS wishes the Minister great luck in her portfolio, and I hope you all will join me in giving her a vote of thanks.
Thank you.